Good morning, everyone. Thank you for being with us today. I'm Nataliia Shyshkina, doctor cardiologist and internal medicine. Today, we're going to talk about one quite interesting and underestimated topic, such as the overlooked connection between osteoporosis and diabetes. So this presentation is only for educational and awareness purposes. This presentation is not a medical recommendation or advice. The outcomes of procedures, techniques, and treatments described here may vary from individual to individual. And in each case, consult a medical practitioner, and this medical practitioner will make decision based on medical testing, treatments, and procedures. After this lecture, you will understand the connection between two diseases. You will recognize some signs and risk factors. You will know when and how to screen diabetic patients for osteoporosis. And of course, we will discuss some treatments, some gaps, and we will give some advice about diet, exercise, etc. This topic matters because rising globally prevalence of this osteoporosis and diabetes. They have shared mechanisms, inflammation, oxidative stress, hormonal imbalance, etc. And it's interesting paradox when type 2 diabetes, well known, can increase fracture risk despite of normal bone mineral density. So a well-known fact that one of the leading causes of death is diabetes, and prevalence of diabetes around the world in 2021, it was more than 500 millions, and it's projected that will be raise more than 783 millions by 2045. At the same time, as you can see, we have the same hip fracture increase projected, and we know that 1 in 3 women and 1 in 5 men globally over 50 years old will suffer an osteoporotic fracture. We know that over time, diabetes, due to high blood glucose level, will lead to serious damage of the heart, of the blood vessels, eyes, kidneys, and nerve system. Patient could have a blindness, kidney failure, heart attack, stroke, lower extremity amputation. Although osteoporosis traditionally has not been listed in this complication list, what I told you, patients with type 1 diabetes and type 2 diabetes are among those at increased risk of this disease. On this slide, I wanted to show you how we under-recognize really this diabetes complication. In Canada, was conducted one survey, very interesting results they had. So more than 80% patients didn't believe that diabetes increase fracture risk, more than 80%. And more than 90% of participants reported that they haven't been informed by their physicians that diabetes increase fracture risk. Just think these numbers. That's why we really never think about osteoporosis in this kind of patients group. Osteoporosis classification, you will listen it in others lectures. I would like just to tell you that we have diabetes mellitus as a secondary osteoporosis reason, and we have this cause keep in mind always when we treat patients with osteoporosis, because both of them age-related disease, and diabetes mellitus is prevalence is rising. So when we will talk about diabetes, I would like to tell you that we will have some differences in osteoporosis as well. Type 1 diabetes, it's a diabetes then that insulin dependent, so a patient has deficient insulin production, and that requires daily administration of insulin. The main causes, it's genetic factors together with environmental triggers, and such as viruses, for instance, leads to autoimmune response, and immune system destroy pancreatic beta cells that produce insulin. On the other hand, we have type 2 diabetes. Here, this diabetes is preventable. You can prevent it if you will take action right now. And more than 95% of patients will have this kind of diabetes, type 2 diabetes. Here we're going to talk about insulin resistance, about beta cells dysfunction eventually, but a lot of things you can change with this. It's correct your obesity, lack of physical activity you can change, and poor diet behavior you can change. So these modified factors could be changed if you will make effort. And here, what we have type 1 versus type 2 diabetes changes and how it's related to osteoporosis risk. So we know that type 1 diabetes bone mineral density is low. And if we compare it, of course, with healthy subjects. And probably that's because of inadequate acquiral of peak bone mass due to hypoinsulinemia and lower level insulin like growth factor, other cytokines, etc. On the other hand, type 2 diabetes has normal to increased bone mineral density, and this related to increased body size. So bone fragility in that kind of people with type 2 diabetes associated with a reduced bone turnover, not because of increased bone mineral density patients has bone fragility, but because of decreased bone turnover. Well-known fact that longer diabetes duration, more than 5 years, is a factor for osteoporosis. Age, in general, type 2 diabetes age-related disease, and osteoporosis age-related disease, and has a metabolic impact as well. But in type 1 diabetes, we have a bit another story. So we have also increased risk of fractures extend across the lifespan. And that is because the initial onset of this disease is quite early in young ages, when bone mass is still growing. So early onset of this disease, diabetes, can lead to long-term skeletal impact. When we use some medications for treatment, for instance, for type 1 diabetes, it's exogenous insulin. Insulin in general has a natural and bone protective effects. It's anabolic to bone. For instance, in type 2 diabetes, certain anti-diabetic medication have affected bone metabolism, and some meds like TZDs reduce bone density. Complications, don't forget that diabetic nephropathy, microvascular events, etc., can lead to osteoporosis changes. For instance, diabetic nephropathy with concomitant secondary hyperparathyroidism and renal osteodystrophy. And it's associated with increased fracture risk. Often patients with both types of diabetes, they have vitamin D deficiency, so you have to check it. Among patients with diabetes, we have some key risk factors to fall. So these falls will associated with increased risk of fracture. And here we talk about poor glycemic control. For instance, hypoglycemia can lead to falls. Diabetic complications, especially if we talk about peripheral nephropathy, foot ulcers, visual impairments, not only retinopathy, but advanced cataract, etc. For instance, if patient frequently go into the restroom at night because of nocturia or polyuria. Age also, we were talking about age-related disease, but at the same time, it has impact on balance or on coordination or on gait. Some comorbidities like hypertension, when patients take antihypertensive drugs, can lead to hypotension. So that's a risk factor to fall as well. So as you can see in this slide, we were talking about falls, increased level of falls, but at the same time, you can understand that a higher risk to have fracture, it's not only about to fall from standing height. It's about altered body composition when patients have sarcopenia, under or overweight, etc. And it's about increased bone fragility. We are talking about not only about bone mass that can change from diabetes 1 to diabetes 2, but we are talking about reduced bone quality. And this reduced bone quality, altered bone quality, it could be due to turnover, impaired osteoblast function, microvascular damage to bones, inflammation, oxidative stress, accumulated advanced glycation and products, etc. As you can see, all of them together can be a risk factor for fall and have fractures in patients with diabetes. Let's skip this slide and let's talk about type 2 diabetes a bit closer. As you can see, when we talk about diabetes, it's all about hyperglycemia and insulin resistance. It's about obesity and their effects. It's about oxidative stress and inflammation, and it's microvascular changes that can affect also age. And you see that all of them together lead to some changes in bone formation. It's getting going down, and bone resorption it's going up through osteoblast and osteoclast mechanism. I will not tell you that right now because you will have another lectures that can affect our bones and can lead to impaired bone quality and what we call diabetoporosis eventually. The cost of this fall. If patients fall down, we can understand that there is some changes will be if it will be healthy person or if it will be a diabetic person. So in conclusion, in this study that was performed more than 10 years ago, scientists said that diabetes was associated with fractures, obviously, and patients with diabetes had more adverse events and subsequent mortality after fracture. Let's see what was there. What was the reason for this? So patients with diabetes, they had delayed fracture healing. Most of the time it was because of infections. They had higher risk of complications after surgery. They had a higher risk of death in hospital mortality. It was 2 times higher. And of course, all of that, as a result, had reduced independence in daily living and, of course, decreased quality of life. Diagnostic gaps we have sometimes when we talk about patients with diabetes. So when we start to test and trying to evaluate osteoporosis, we start from FRAX. This tool can help us with 10-year structural risk assessment. We can estimate it, but it will be underestimated in type 2 diabetes patients. The same story here with DEXA. So DEXA is a golden standard. You will hear about it today and following days a lot. And it's a golden standard to measure bone mineral density. And here we go. It's underestimated fracture risk in type 2 diabetes because fracture may occur even with in patients with higher bone mineral density because of poor bone quality. What can help us with this? Additional test to DEXA, it's trabecular bone score. That can help us to estimate bone quality, microarchitecture, and that can help us with patients with type 2 diabetes. It's very useful. Don't forget that very common in elderly diabetics, vertebral fractures, and they're silent, these vertebral fractures. So detect these silent vertebral fractures, we can do vertebral fracture assessment. Other test, it's laboratory test. It's vitamin D status. It's essential for bones. It's parathyroid hormone. We were talking about secondary hyperparathyroidism. It's serum calcium and phosphate in blood test. It's renal function. We check creatinine for it. This is quite important for our treatment, for vitamin D3 activation, for drug choices, especially biphosphonates. We can check bone turnover markers. I told you about type 2 diabetes is more important, and some parameters can say it's about resorption and formation, and it's low in type 2 diabetes. We have to know how our patient control glucose, and we check hemoglobin A1C for it. Very useful test and very easy to do it. It's a full risk assessment. Time to up and go, gait speed, grip strength, all of them is very useful for us. So what is going on with FRAX and DEXA? With FRAX, patients with type 1 diabetes, this tool is not appropriate for assessing. Patients type 2 diabetes, in FRAX tools, it's not isn't considered as a secondary cause of osteoporosis. But type 1 diabetes, it is considered, so you can tick this box. For instance, FRAX underestimate fracture risk in patients with type 2 diabetes when they have longer duration, more than 10 years, for instance. DEXA. I mentioned it already that with DEXA, when we have to do, if patients have type 2 diabetes and normal and or higher bone mineral density, we have to just add one extra test, it's trabecular bone score. Let's go through this algorithm. You will find it, I put link here, you will find it in article. It's very easy and will help us to structurize whatever I said before. So if patients have some risk factors, we will check their check their bone parameters. So duration, more than 5 years of diabetes, micro or macro complications, hemoglobin A1C more than 8, hypoglycemia risk, using insulin or other drugs for anti-diabetic drugs with negative effect for bones. So we have to perform thoracolumbar X-ray for asymptomatic vertebral fracture assessment. We have to do DEXA, and if it needs, consider TBS as additional tool. If we do assessment by FRAX, for instance, for type 1 diabetes, we just need to select secondary osteoporosis. Here is clear. For type 2 diabetes, we can use some other calculators like FRAX Plus or Q fracture. If we use FRAX, just adjust it a bit. For instance, reduce the score by 0.5, increase age by 10 years, select rheumatoid arthritis as a comorbidity, etc., etc., etc. For all patients with diabetes and osteoporosis, we have to select glucose-lowering medications with neutral and beneficial effects on our bones, maintain adequate vitamin D level, and assess false risk and improve physical function, etc. Today you will take part in one lecture about this echolyte bone ultrasound measurements. This echolyte, it's a safe alternative to DEXA. It's non-invasive, it's radiation-free technology, it's quite affordable for measurement bone density, bone quality, bone strength, etc. And if you are a woman over 40 years old, if you have diabetes, hormonal replacement therapy, some imbalance, a low or high body mass, etc., you can consider this test like safe alternative to DEXA. And another steps will be treatment. So we're going to talk about conventional treatment and regenerative treatment. Let's start from these two documents. You can find it in internet. So that's some kind of like guidelines for patients with guidelines for doctors who treat patients with diabetes and osteoporosis. You remember that we have 6 pillars of health: nutrition, physical activity, managing stress, relationship, and social connection. I believe that there in this conference hall, you don't have any problem with these pillars. Restful sleep and avoiding risky substances. So when we talk about lifestyle, I always mention that lifestyle is a medicine. And we start with diet. Consider the Mediterranean diet. And it's healthy for diabetes, and it have a lot of benefits for bone health. Limit foods high with added sugar, sodium, alcohol, caffeine. Prioritize fruits, vegetables, whole grains, healthy fats, and lean proteins. Don't forget and focus on consuming adequate calcium. I'm not saying only about supplements. I'm saying about food, juices, and vitamin D. Then, as doctors, we have to talk about fall prevention strategy with our patients. What does this strategy mean? That patient has to wear some proper footwear. They have to do exercise to improve their strength and balance. They have to make their house safe. They have to take pills with control, etc. Then it's intense walking and exercise. So I want to highlight for you today, if you are not going to do any exercise, don't think that you will have good results eventually, because exercise It's something that you cannot skip. It's something that can help you even without any pills. So intense walking. If you want to run far away from diabetes, use this advice: 150 minutes per week at least. And you have to add it with weight bearing, with resistance trainings, and it's very healthy for bones and for glucose. Of course, sleep, stress management, circadian rhythms. I call it like basic needs. You just need to manage it as soon as possible. Of course, glucose control should be every day, week, whatever doctor will tell you how often to do that. Don't forget about complications, because these complications will eventually lead to some fractures. For instance, hypertension. Most of the time, hypertension is coexist with diabetes. So when you treat a patient with antihypertensive agents, be aware that you have to teach them how to avoid hypotension, and we have to adjust those. Others, it's meetings and annual checkup with ophthalmologist, with neurologist. So we do annual checkup by fundoscopy, and we do annual checkup neuropathy assessment. Vitamin D. We start from this because I told you about focusing on consuming. Sometimes we don't have enough vitamin D, so we have to use supplements. And here I would like to show you MF3 Immunovit. In this product, we have vitamin D3 plus K2. Why we have K2 together? Because they work synergetically for bone health. Vitamin D, from one hand, support calcium absorption, bone mineralization, improves metabolism in the bones, reduce inflammation, oxidative stress, support bone cell longevity, and at the same time preserve bone quality with aging. All of that together leads to a reduced risk of fractures. But on the other hand, we have K2 vitamin, and this is essential for us. If you take only vitamin D3, be ready for some complications of your treatment. So vitamin K2 activates osteocalcin that help us with calcium bonding in bone, but other effect prevents calcium deposition in arteries, in soft tissues. That's about prevention of vascular calcification. So if you don't take K2 and you take only vitamin D3, be ready that you will have a problem with the vessels and you will have vascular calcification, so your condition will become worse. So that's why we add K2 in MF3 Immunovit, and it's only for your benefits. All patients with type 2 diabetes and elderly patients, in majority, they have a deficiency of magnesium, and this magnesium, without this magnesium, vitamin D remain inactive. And for activation and metabolism of vitamin D, we have to use additionally pill of magnesium. This is a conventional treatment from guidelines. I just made it in a table for your to read it easily for you. So anti-resorptive treatment, it's a first step for bone treatment, and we have here bisphosphonates, we have denosumab and raloxifene. Of course, we have others, but it's another slide. So biphosphonates, here we have three molecules of these biphosphonates. In general, they increase bone mineral density, they reduce fracture risk, and they reduce bone turnover. Some cautious we have in case of nephropathy, when patients have these diabetic complications, we have to think about biphosphonates and make decision exactly individualized for this patient. Denosumab increase bone mineral density, decrease vertebral fractures, but some of the trials said that it can increase non-vertebral fractures. So we need more trials and more research in this area. Raloxifene reduce vertebral fracture risk in women with type 2 diabetes and no other adverse events, so it's very safe. Anabolic therapy, it's preferred in type 2 diabetes due to low bone turnover. And this, what you can see here, it's some molecules that can help you with bone mineral density and with bone strength and others. On this slide, with anti-diabetic drugs, I would like to stay a bit longer because here we have some controversial results. Let's start from metformin. Nothing here can concern us. So in general, it's common used drug for first line treatment, no fracture concern. Risk, and metformin has a natural or beneficial, even positive effect on our bones. Next, it's dipeptidyl peptidase 4 inhibitors, and everything that have ending of the word gliptins, it's this kind of group. It's for your better understanding. So they can possibly even increase bone formation. They can suppress bone resorption in preclinical data. So this is preferable group of drugs that we can use for patients with osteoporosis and diabetes. Other group, it's glucagon-like peptide 1 receptor agonists. Here we're going to talk about glutides, semaglutide, remember, yes, liraglutide, tirzepatide. So in general, when you will see this group, in articles, they say that it can prevent bone mineral loss during weight loss, and it has natural or beneficial effects. But however, yeah, we have here something else. For instance, in some of the molecules, I will make an example with semaglutide. We use it, it's like a bomb right now. Yes, everyone talking about it. Everyone take it for only weight loss or only for diabetes with weight loss. So it's very common treatment right now. And some of the studies, they said that this semaglutide has potential effect for reduced risk of osteoporosis. Other research, they said that they indicate in these studies that semaglutide may lead to reduced bone mineral density, higher bone resorption. So this rapid weight loss without any exercise can lead to some changes in our bones. Why I started talking about it? Because I have to make effort right now to pursue you to do exercise, because without exercise, when you lose weight, you lose not only fat tissue, you lose lean muscles. And nowadays, these lean muscles, they everywhere consider not only as a muscular support, it's a hormonal organ and others effects. So when you lose lean muscles, of course, you will have consequences on your bone health. So if you would like to take any anti-diabetic drugs, such as this, what I mentioned, you have to understand that you have to adjust your diet, you have to change your lifestyle, and you have to start to do physical activity like doctor recommend you. Without this physical activity, it's the most important pillar. It will not work as you wish. So you will lose weight, but what is the cost of this loss? Okay, others, it's SGLT2 inhibitors. Here, I would like to say that we have mixed data, and we have some controversial results. So everything that finish with gliflozin. Yes, I mentioned before ganagliflozin or other gliflozin. Here, you have to be very careful, and no consistent increased fracture risk, keep it in mind. Others, TSD, what I mentioned today a million times, that group can lead to increased fracture risk and reduced bone mineral density. And then this group, the end of this name of these groups will be glitazone. Okay, everything what is glitazone that have to make you think twice and avoid to prescribe this in high-risk patients, especially in women. Sulfonylureas can increase the risk of non-vertebral fractures, but here is likely due to hypoglycemia-induced falls. Something very similar happened with insulin. I told you that insulin is quite useful for us, but it can increase fracture risk despite of anabolic potential, and it's likely due to falls. It's the same, and it's likely because, for instance, type 2 diabetes patients, they have already advanced disease. They have a longer duration of diabetes. They have already poorer glycemic control. They have complications such as retinopathy or neuropathy. So it's not really direct effect, but it's indirect effect through all of what I mentioned. Red light, green light. I told you that we have some drugs that have neutral and positive effect, such as metformin, DPP-4 inhibitors, GLP-1 receptor agonists. With them, you can see good results with your treatment. If you're gonna prescribe something with red light, it's TSD, yes, what I mentioned. So these glitazones, they have a negative effect for our bones formation, and we have to avoid these drugs. If we talk about yellow, it's like some risks, some benefits. It's a group of sulfonylureas, insulin, ganagliflozin. So just be aware that not every anti-diabetic medication has the same effect, and you have to do your personalized prescription. So what is going on with our target? Everywhere we check hemoglobin A1C just to check what kind of glucose control our patient has. And the longer duration of type 2 diabetes presents some kind of cardiovascular disease or complications, some severe hypoglycemia, perhaps in some cases can pursue us to make a bit higher hemoglobin A1C target, around 7 and 5, 8, sometimes just to avoid hypoglycemia risk and risk of falls and risk of fractures through this mechanism. Metformin, I mentioned it before, it has various positive effects such as anti-aging, increased lifespan, help with weight loss and heart disease, but it has a lot of benefits with bone health that because metformin may play a role in important role in osteoblast differentiation and bone formation. It's except all pleiotropic effects what metformin has on other organs, okay? It's just additional benefits for us. What we can do else with diabetes? We can control blood glucose level with, for instance, with Natura glucose management. This product consists two different ingredients, AGCG and berberine, and both of them except effect for our blood sugar level that regulates this, effect on inflammation that have anti-inflammatory effects, that affect some mitochondrial function and increase insulin sensitivity. Both of them have a potential effect on bone resorption. It's inhibited or promote bone formation when, for instance, berberine can inhibit osteoclastic activity and potentially improve bone density. So this product can help you to control your blood sugar and to prevent or even help in treatment of osteoporosis. Potentially, you have to remember that this product can increase effect of others diabetes medications. It's potentiated, so we have to adjust our dose of anti-diabetes medications, or we have to adjust some other parameters. Omega-3. here we talk about omega-3, and it has benefits for glycemic control. It has benefits in cardiovascular benefits and benefit in cardiovascular system. But it has also positive effect on our risk of osteoporosis. It will reduce a risk of osteoporosis because of bone density changes. It will improve, and because of improvement in bone turnover. But remember about bleeding risk, because higher doses of omega-3 may increase bleeding risk, and especially it's important to remember in patients with anticoagulant treatment. We have MCE evolution in MF3. And in this product, we have a lot of active ingredients that can be useful for osteoporosis treatment. So let's go through it. Marine cellular extract boost collagen, tissue regeneration, have support effect on our bones and muscles. Glycosamine glycan, everyone knows about this ingredient when we talk about osteoarthritis. It supports collagen, but at the same time, it can support bone matrix and have anti-inflammatory effect. Krill oil and fish oil. So this is omega-3. And this omega-3 can reduce bone loss, may support bone metabolism. So quite a lot of benefits just in one pill. Others, they have indirect support and for diabetes and for bone strength. Here we go and to talk about alpha lipoic acid. We talk about some omega-3 from fish oils. Here it's a plant plant sources, based sources. So here I would like to tell you not about osteoporosis effects, but about diabetic polyneuropathy. So if we will treat diabetic polyneuropathy, patient will not fall and will not have any fractures. So these have indirect effect for our osteoporosis treatment. And of course, this ALA can reduce oxidative stress, and that can affect bone turnover. Right now, we're going to talk about innovation in regenerative medicine, and it's about stem cells, peptides, and exosomes. I will not talk about stem cells for long right now, because after me, you will have fantastic presentation. But here, I just wanted to tell you that some of the cells that you probably can use for diabetes, they will have benefits and for osteoporosis treatment. For instance, placenta that we can use for growth factors, hormones, stimulate cell regeneration and overall well-being. It will be useful for bone repair and osteogenesis. For instance, if we talk about liver, liver, it's target organ for diabetes, so we use it there. And liver health affect vitamin D metabolism and insulin like hormone factor 1 and etc. So it will affect bone growth. Gonads. It's sex hormones, estrogen, testosterone. Today you had a lecture about it. That's a key for regulation bone metabolism, and it will help, especially men, to increase testosterone, to build muscles, to boost metabolism, etc., etc., etc. And that will help improve glucose control as well because of better glucose utilization. Heart, arteries, retina, kidney. All of that, it's target organs for diabetes. But at the same time, if you will treat secondary complications, you will not lead to some problems like fall and fractures. At the same time, kidney, for instance, except nephropathy that patient can have, if we use kidney stem cells, it can be critical for us because it will help us with activation vitamin D, with calcium phosphate balance, etc. Of course, for osteoporosis, it's very crucial to use mesenchyme cells because of it's the most relevant stem cells, because they should be used for bone regeneration and fracture healing. So that's we have to remember. And osteoblast, its direct role in bone formation. So no need to explain why it will improve bone mass. Mitochondrial peptides, today you had lecture also about it, mitoorganelles, MO from MF3, or NOP, nano-organopeptides from MF3, that have a lot of different effects, such as repair damage mitochondria, or mitochondrial improvement, or helping in energy production, etc. But it will reduce oxidative stress. It will help you to grow and reproduction function of the cells. So it will help you with osteoporosis and with diabetes, because it has a necessary structural material for intercellular proteins synthesis, for paracrine effects on tissues, etc. And exosomes. Just lately, recently, that molecules were found. So these molecules secreted by stem cells, and they play essential role in cell-cell communication. What these exosomes can do? They can inhibit the inflammatory response, and they can promote vascularization, angiogenesis. They can promote bone formation by repairing. They can help you with bone tissue regeneration that based on osteogenic proliferation and migration of MSC in vitro. And it was also demonstrated in vitro that it can increase osteoblast cells, it can reduce cell apoptosis and systemic inflammation. Of course, it will have bone regeneration effect, angiogenesis, and osteoporosis progression will be slower, and bone loss will be slower. So as you can see, a lot of effects for osteoporosis. The same we have for diabetes. Exosomes, most of the time, used for diabetes when we want to restore B cells function, when we want to decrease insulin resistance, and we stimulate pancreatic cells regeneration. As a conclusion, I just want to briefly remind you what we were talking about. First of all, fracture risk exists even in with normal bone mineral density, and type 2 diabetes patients are example. Fracture risk is higher in patients with type 1 diabetes than type 2. Patients with poorly controlled diabetes, complications with longer duration of disease are at higher risk of having future fractures. While bone mineral density is different, bone quality is impaired in both cases, in type 1 diabetes and type 2 diabetes. We have to monitor bone health in patients who is taking insulin or SGLT2 or with weight loss, etc. We have to consider anti-diabetic drugs with bone natural or bone-friendly, let's say, profiles. As a takeaway messages, I would like to tell you that bone fragility is not always reflected by bone mineral density. Fracs underestimate risk, especially in type 2 diabetes. Address fall risk, neuropathy, and hypoglycemia in your treatment. Individualized treatment based on duration, comorbidities, renal function, etc. And try to use a diabetic-centric approach when you treat patients with osteoporosis. It will help you to make it individualized and personalized. Thank you for your attention. Finally, over. I wish you the good day there. And I think that next lecture, it will be so fantastic that you will forget about diabetes in 1 second. Have a good day there.